is a nerve of second brachial arch. It supplies the muscles of facial expression, and the main peculiarity of the facial nerve is that it has so many peculiarities. The most important one is that it is very closely related to the ear. And to become a best otological surgeon, you should love and respect facial nerve and make facial nerve your best friend, know everything about the facial nerve. If you are not going to do that and going in after going to do an otological surgery without knowing anything about the facial nerve, what will happen? The next morning you will go and see the patient and the face will be facial nerve palsy, and you will be the worst otological surgeon or worst person to the patient and the relatives. So this facial nerve arises from the main centers, from the face area of the cerebral cortex, upper midbrain, the lower brainstem, the pons and the medulla. Okay. Right? And the facial nerve has got motor as well as sensory root. And there are mainly 4 nucleus for the facial nerve, and all are located at the lower border of pons. And this is a pons and this is a medulla. So this is the facial nerve proper. Right? This is the facial nerve proper. Facial nerve proper or the branchiomotor nucleus, because it supplies the muscles of facial expression. That's arising from the second brachial arch, so it is called the branchiomotor nucleus. I already told facial nerve has got so many peculiarity. The other one is that usually every motor fibers from the motor nucleus go forwards. So actually they should go forward. They should emerge from the pondomedullary junction. But what happens here? Somehow the facial nerve, on trying to exit from its motor nucleus, it had someone calling from behind. Okay. So what happened? It went backwards. Fibers went backwards. What is here in the back? This is the floor of the fourth ventricle. There is a fibers are going backwards towards the floor of fourth ventricle. It reached the floor of fourth ventricle. Look there. Made a facial colliculus. Right? Made a swelling in the floor of fourth ventricle. And this is called the facial colliculus. And it realized that it was my hallucination. Nobody is calling from the floor of fourth ventricle. So I have to go forwards. Right? So it's tried to turn. But what was there? Sitting? Obstructing the way of seventh now. What was there? It was the sixth nucleus. Abducens nucleus. So what happened? Facial nerve wound round the abducens nucleus and exit from the pondomedullary junction. Okay. So this facial nerve it first went backwards, made a swelling in the floor of fourth ventricle as the facial colliculus. Then it curved round the sixth nucleus and went out. This is the pondomedullary junction. When if I am drawing the frontal view, this is the pons and this is the medulla, right? Here, see, abducens nerve should come from here, sixth, and here comes the cerebellum. Okay, so this facial nerve along with the This is the facial nerve. Which nerve accompanies the facial nerve? Along with the facial nerve goes the eighth nerve, vestibulocochlear nerve. Okay. So vestibulocochlear nerve also comes here. So both this 7 and 8. This 7 and 8. Both this now they exiting more laterally around up from the CP angle, cerebello-pontine angle. So at the cerebello-pontine angle they are exiting along with the eighth nerve. So that is about the motor nucleus. Okay. And I also told there is also sensory fibers. Right? There are sensory fibers. Which all sensations are from the facial nerve? And if you become very sad, tears will come, isn't it? And if you are very angry, what will happen? Saliva will come to your mouth, isn't it? You can spit your enemy, right? So, that part, that is the parasympathetic fibers. Your parasympathetic fibers. Okay. Parasympathetic fibers. Which is the nucleus for parasympathetic fibers? Actually, this nerve goes and supplies the lacrimal gland, parasympathetic, general. For a punch, you can call it as a general visceral efferent. Okay, parasympathetic. So, parasympathetic fibers, parasympathetic preganglionic fibers go to the lacrimal gland and also to the submandibular and the sublingual glands, and also supplies the glands in the nose and palate. Okay. So, fibers are also situated here at the lower border of pons. The fibers for tearing and for the saliva. Right? Tears and saliva. What is it called? Actually, it should be called as a lacrimo-salivatory nucleus. Some textbooks tell it as a salivatory nucleus, and some call it as a superior lacrimatory nucleus, and some textbooks tell it as a superior salivatory nucleus. Okay. So this is the superior salivatory nucleus. Right? Superior salivatory nucleus for tears and also for the saliva. That is a parasympathetic preganglionic fibers or general visceral efferent fibers. Okay. And what is the another sensation that carries through the facial nerve? Through the chorda tympani. Which is that? Which is that fibers? It is, you have your tongue, isn't it? Your tongue muscle. Right? This is circumvallate papilla, divides it into an anterior 2/3 and a posterior 1/3. Isn't it? So the anterior 2/3 taste fibers or taste sensation from the anterior 2/3 of tongue. That is the gustatory fibers through the chorda tympani. They are also coming here. What is that? Taste fibers. Taste fibers. Not only from the anterior 2/3. Anterior 2/3 it is from the 7th nerve. And the posterior 1/3, which nerve carries the taste? It is the 9th. And from your epiglottis and from the lower border of vallecula, it is the 10th nerve. So 7, 9 and 10 are involved in taste fibers, and all this will come to the nucleus of tractus solitarius. Here, this one. Nucleus of tractus solitarius, right? Nucleus of tractus solitarius. So that is for the taste fibers. And one more sensory root is there. What is that sensory fibers? Sensory fibers from the root of pinna and the posterior part of the external auditory canal. Sensory supply of the face is through the trigeminal nerve. Fifth nerve. This fifth nerve has got a mesencephalic nucleus, a pontine nucleus here, and has got a spinal nucleus. So this is the fifth one. This goes and supplies this, and this fibers go to the trigeminal nucleus, because trigeminal nerve is the main sensory supply of the face, right? Okay. This motor nucleus of the facial nerve has got an upper part and a lower part, and this upper part supplies the upper face. This forehead and around the eyes. Forehead, muscles of forehead and muscles around the eye, supplied from the upper part of the facial nucleus, and then receives cortical fibers mainly from the contralateral side. This from the contralateral side and also from the same side, right? But lower part only from the opposite side. Okay. So the upper part of the facial nucleus, which supplies the muscles of forehead and around the eyes, get a bilateral innervation, whereas the lower part get only the from the opposite cortex, and the emotional innervation is from the thalamus. Thalamus. Emotional movement. Okay. So that is why if you have a supranuclear lesion of one side, this upper part of face and emotional movement will not be affected, right? Facial nerve exit the pontomedullary junction at the CP angle as the main facial nerve proper of the motor root, and this will be the sensory root. All these three, that is the parasympathetic, preganglionic, then the taste sensation from the anterior two-third of tongue, and sensations from the root of pinna and posterior part of the external auditory canal. That these three will form the sensory root, and this is called the nervus intermedius. Nervus intermedius or nerve of Brisberg, right? Nerve of Brisberg. Facial nerve proper along with the nervus intermedius, after exiting from the CP angle, right? This is the anterior cranial fossa, this is the middle cranial fossa, and this is the posterior cranial fossa. And in the middle cranial fossa, below the middle cranial fossa, there is one important landmark. What is that? It is the middle. Remember, the tegment plate separates the middle from the middle cranial fossa. So if I draw the middle here, this will be the medial wall of the middle. It's a medial wall of middle, posterior wall, floor, and here comes your anterior wall. Okay. This is a medial wall with the promontory, oval window and the round window. And what is there in the anterior wall? There is a foramen for eustachian tube and also for the tensor tympani muscle, right? So how this facial nerve reaches the middle ear, and we can see that how this facial nerve reaches the middle ear. So from the CP angle, this facial nerve enters another canal, that is the internal acoustic canal or the internal auditory canal. Like the external auditory canal, there is an internal auditory canal that passes from the CP angle through the temporal bone. It passes laterally. So from here this internal auditory canal comes. So this is the internal auditory canal, right? Right? This is the internal auditory canal. So in the internal auditory, actually this internal auditory canal can be asked as short note. It is a 1 centimeter long tube. It is 1 centimeter. Internal acoustic meatus or the internal auditory canal is length of 1 centimeter. It passes from the CP angle through the petrous bone laterally, and inside it is lined with dura mater. And inside the internal auditory canal also, this facial nerve proper and this sensory root will run as two separate entity also. Okay. Facial nerve proper and the sensory root also will run as separate. And inside the internal auditory canal also, this facial nerve proper and the sensory root will run separately, right? As two nerves. Along with the facial nerve, there is another nerve which goes always hand in hand, that is the vestibulocochlear nerve. That is the 8th nerve or the vestibulocochlear nerve. Also runs along with the facial nerve. It is the vestibulocochlear nerve. Right? That also runs along with the 7th nerve. This is the 8th nerve and this is the 7th nerve. 7th nerve with a motor as well as a sensory root separately, and they will reach up to the lateral end, and the lateral end of the internal acoustic canal is closed by a plate of bone which is called the lateral end of the internal acoustic canal is called the fundus, and that is closed by a plate of bone which is porous in nature. And along with the inner ear, I have talked so many times about this fundus, which is related to the medial end of the cochlea. Through the fundus goes the facial nerve, cochlear nerve, superior and inferior vestibular nerve, along with the cingulate nerve. So at the lateral end of the internal acoustic canal, this part is also, you have noticed, this much length is not yet, it's constricted a bit. And there is a porous plate, right? Here. It's a plate of bone. So I will draw this part, that is the fundus or the lateral end of the internal acoustic canal. It will be almost like this. And it is separated into two halves by a falciform crest or transverse crest. This is called the falciform crest. Falciform crest, and this crest separates the internal acoustic canal into a smaller upper compartment and a larger lower compartment, and through the upper compartment goes the facial nerve. And what happened to the nervous intermediates here? At the fundus of the internal acoustic canal, this nervous root or the nervous intermediates comes into the fibers of the facial nerve proper or the motor root. So it will be almost like here, like this facial nerve proper and the nervous intermediates were separate till the fundus of the internal acoustic canal, and on reaching the fundus of the internal acoustic canal, both goes to the same canal, same facial canal, and also this nervous intermediates goes into the fibers of the facial nerve proper. So It will be somewhere here, right? And the facial nerve proper comes in. Okay. And this is anterior, posterior, superior and inferior, right? So in the upper part, anterior compartment lies the facial nerve, and in the posterior compartment goes the superior vestibular region. Superior vestibular region, and these two are separated by a bar or thick plate of bone called, it's a bar, it's not the bar, usual bar, you know, it is called the Bill's bar. Bill's bar, right? And in the inferior part, inferior lower compartment, anteriorly lies the cochlea and posteriorly goes the inferior vestibular region. So superior vestibular nerve supplies which all structures? It supplies the ambulated end of the superior and the lateral semicircular canal, utricle and the part of saccule, and the inferior vestibular nerve supplies the saccule. So which supplies the posterior ambulated end of the posterior semicircular canal? It is the singular nerve. So this is the structure of the fundus of the internal acoustic canal, which is separated into an upper, lower, smaller compartment and a larger lower compartment by falciform crust or the transverse crust of bone. And in the upper part, anteriorly comes the facial nerve, posteriorly is the superior vestibular region separated by the Bill's bar, right? And lower compartment, anterior part, cochlea, posteriorly inferior vestibular nerve region, and postero-inferiorly comes the region for the singular nerve canal. And one more thing you have to know about this Bill's internal acoustic canal is, remember a name, that is valvasori and Pierce. They described much about this fundus of the internal acoustic canal. For an ENT surgeon, this CP angle tumor, especially acoustic neuroma, is very important, which arises from this region. So there is a Vibratory criteria to know the erosion or the enlargement of the internal acoustic canal. What is that? Vibratory criteria. That is, in 90% of the normals, this vertical diameter, this vertical length is around 2 to 8 millimeter with an average of 4.5 millimeter. Okay. So this vertical dimension of the internal acoustic canal is around 4.5 millimeter, and this posterior length of the internal acoustic canal, the posterior wall, length of the posterior wall comes around 9 millimeter. Okay. So if there is an enlargement or dilatation of the internal auditory canal by an acoustic neuroma, we have to do an radiological examination, and we have to compare with the two sides, normal and abnormal. So normally the difference between the vertical dimensions of the two sides, one side it is 4.5 millimeter, so the difference between the two sides should not exceed 1 millimeter, right? Normally the difference between the two sides in vertical length, the diameter, should not exceed 1 millimeter, and I said the posterior wall length is around 9 millimeter, and the difference between the two sides should not exceed 2 millimeter. If this is exceeding this 1 millimeter and the 2 millimeter, think about some pathology in the internal acoustic canal. So, from the CP angle through the internal acoustic canal, it reaches up to the fundus. What is here actually? Here comes your cochlea. Right? Your semicircular canal, superior, posterior and the lateral semicircular canal. And here is the vestibule. So, this is the fundus. So, from the fundus, this facial nerve along with the nervous intermediates reaches into another canal, that is a facial